We are convening this session of the IUCS Journal Club to address what is arguably the most significant paradigm shift in the perioperative management of muscle-invasive bladder cancer that we've seen in decades. We are essentially looking at a bifurcated treatment landscape that has emerged from two recent landmark Phase 3 trials, namely EV-303 and NIAGARA.
Right. It is a complete restructuring of the standard of care. We are moving from a monolithic approach, which was largely defined by cisplatin-ineligibility and radical cystectomy, to a much more nuanced, stratified algorithm. And this involves antibody-drug conjugates and checkpoint inhibitors in both the neoadjuvant and adjuvant settings.
Exactly.
The objective for our deep dive today is to really analyze the efficacy signals, the toxicity profiles, and the implementation challenges of introducing enfortumab vedotin plus pembrolizumab for the cisplatin-ineligible population, alongside durvalumab plus gemcitabine and cisplatin for the eligible cohort.
Precisely. We need to move beyond the historic standard of radical cystectomy alone, or MVAC and GenCis. Let's begin with the cisplatin-ineligible cohort, specifically looking at the data from EV-303 that was published in the New England Journal of Medicine. This trial compared perioperative enfortumab vedotin plus pembrolizumab directly against surgery alone. And the efficacy signal here is, frankly, startling.
Startling is definitely the appropriate adjective there. If we look at the primary endpoint, event-free survival, the hazard ratio reported is 0.40 with a 95% confidence interval of 0.28 to 0.57 and a p-value of less than 0.001. In the context of solid tumor oncology, an HR of 0.40 in a Phase 3 setting is exceptionally rare. We are talking about a 60% reduction in the risk of progression, recurrence, or death compared to radical cystectomy alone.
Yeah, to contextualize that for you when you're sitting in the tumor board, the 2-year EFS estimate was 74.7% in the experimental arm versus 39.4% in the control arm. That is a delta of over 35 percentage points. And this translated to overall survival as well.
It did. The OS hazard ratio was 0.50 with a confidence interval of 0.33 to 0.74. Statistically significant, obviously. This data essentially establishes EV-pembro as a mandatory consideration for any patient meeting the ineligibility criteria who is heading towards cystectomy. But the metric that often drives the surgical conversation, as you know, is the pathologic complete response rate.
Right. The PCR data in EV-303 is unprecedented in this specific population. The study reported a PCR rate of 57.1% in the EV-pembro arm. Compare that to the control arm at 8.6%. That's a difference of 48.3 percentage points. Furthermore, pathologic downstaging to less than PT2N0 occurred in 65.9% of the experimental arm.
It's a massive signal. However, we must be intellectually honest about the comparator here. EV-303 compared this regimen against surgery alone because these patients were ineligible for cisplatin. This differs fundamentally from the NIAGARA trial, where the control arm actually received active chemotherapy.
Let's pivot to NIAGARA then. This covers the cisplatin-eligible cohort, comparing perioperative durvalumab plus GemCis versus GemCis alone. The bar is obviously higher here because the control arm is the current gold standard.
Correct. And despite the active control, NIAGARA met its primary endpoint. The hazard ratio for EFS was 0.68 with a confidence interval of 0.56 to 0.82. The 2-year EFS was 67.8% for the durvalumab arm versus 59.8% for the chemotherapy-only arm.
And regarding overall survival?
The OS hazard ratio was 0.75, implying a 25% reduction in the risk of death. Now, while an HR of 0.75 is less dramatic than the 0.50 we saw in EV-303, it is arguably just as clinically significant.
Because it demonstrates superiority over an active, life-prolonging regimen.
Exactly. The PCR rates also showed improvement, so 37.3% in the durvalumab arm versus 27.5% in the control.
So, synthesizing the mechanism here. In the cisplatin-ineligible group via EV-303, we were seeing an antibody-drug conjugate combined with a checkpoint inhibitor, delivering a profound hazard ratio reduction in a historically poor prognosis population. In the eligible group via NIAGARA, adding an IO to standard chemotherapy yields a solid, statistically significant benefit, though the magnitude of the delta is naturally compressed by the efficacy of the backbone chemotherapy itself.
That's a very accurate summary. The ADC-IO combination in EV-303 appears to be a more potent, localized induction engine, which is evidenced by that 57% PCR rate, whereas the NIAGARA approach is really optimizing the established cytotoxic backbone.
Let's interrogate the methodology and patient selection, as this is where the clinical application gets complicated for you in everyday practice. The definition of cisplatin ineligibility is crucial for EV-303. The trial utilized Galsky criteria.
Yes, specifically creatinine clearance, less than 60 milliliters per minute, which represented about 60% of the cohort. ECOG performance status 2 and hearing loss were the other primary drivers. And it's worth noting that the trial modified the criteria to omit peripheral neuropathy as an exclusion for enrollment.
Which is highly relevant given the toxicity profile of enfortumab vedotin.
Exactly.
Contrast that with NIAGARA, which required cisplatin eligibility. In daily practice, we often see patients who are borderline eligible. Maybe their creatinine clearance is fluctuating between 50 and 60. Based on these two data sets, the temptation to label a borderline patient as ineligible just to access the EV-303 data is non-trivial.
That is a dangerous temptation if not managed carefully, but the data does suggest that the ineligible patients in EV-303 achieved outcomes that rival or exceed the eligible patients in NIAGARA, at least in terms of PCR. However, trial design differences matter here. EV-303 utilized 3 cycles of neoadjuvant therapy followed by surgery, then 6 cycles of adjuvant EV and 14 cycles of adjuvant pembro. That is a heavy adjuvant burden.
Whereas NIAGARA used 4 cycles of neoadjuvant durva plus gemcis, followed by 8 cycles of adjuvant durvalumab. So the duration of treatment is significantly different. I want to touch on the subgroup analysis regarding PCR and survival. We traditionally assume that PCR is the surrogate for survival.
Right, but the subgroup analyses in both trials challenge the binary nature of that assumption. In EV-303, patients with a PCR had a hazard ratio of 0.43. That's expected. But crucially, patients without a PCR still showed a hazard ratio of 0.76 with a confidence interval of 0.51 to 1.14.
So this suggests the benefit of the ADC-IO combination extends beyond just those who achieve a complete pathologic response.
Exactly.
And we see a similar trend in NIAGARA.
We do. In NIAGARA, the survival benefit was preserved regardless of PCR status. The HR was approximately VANCH 0.58 for responders and 0.77 for non-responders. This is vital for your tumor board discussions. Failure to achieve PCR does not mean the neoadjuvant therapy was a failure in terms of long-term survival probability.
From a surgical perspective, feasibility is obviously the primary concern with these novel agents. In EV-303, 87.6% of patients in the experimental arm underwent surgery. In NIAGARA, completion rates were similar between arms.
The data indicates no signal for increased surgical morbidity or delay attributable to the IO component in NIAGARA, nor the ADC component in EV-303. However, the nature of the toxicity leading up to surgery is distinct.
This brings us to the clinical integration and toxicity profiles. This is where the operational shift occurs for urologists and oncologists. We are moving from managing renal protection and hydration with cisplatin to aggressive monitoring of dermatologic events and sensory neuropathy with enfortumab vedotin.
The toxicity load in EV-303 is substantial. Grade 3 or higher adverse events occurred in 71.3% of the EV-pembro group versus 45.9% in the control. The specific profile is what demands attention. Skin reactions occurred in 57.5% of patients, with severe grade 3 reactions in roughly 11 to 13%. Peripheral neuropathy was reported in 36.5% of patients.
And there were fatalities.
Yes. There were 3 drug-related deaths during the neoadjuvant phase in EV-303, including toxic epidermal necrolysis and myasthenia gravis. These are immune-mediated and direct toxic effects that require immediate recognition. A patient developing a rash in the neoadjuvant setting on EV-pembro is not the same as a patient developing a rash on gemcis. It requires immediate intervention, often high-dose steroids or cessation.
Compare that to NIAGARA.
NIAGARA's toxicity profile was broadly similar to the chemotherapy-only control arm. Grade 3 and 4 AEs were approximately 69% in the experimental arm versus 68% in the control. The profile is consistent with the known effects of gemcis and durvalumab. We didn't see new immune-related safety signals that would compromise surgical candidacy.
So for the urologist, the NIAGARA regimen feels familiar. It's gemcis plus an infusion. The EV-303 regimen, however, introduces a new spectrum of adverse events that can complicate the perioperative window. Peripheral neuropathy, in particular, is a major concern for patients facing radical cystectomy and potential urinary diversion.
It necessitates true multidisciplinary coordination. If a patient develops grade 2 neuropathy during the 3 cycles of neoadjuvant EV, does that influence your decision regarding an orthotopic neobladder? It certainly should. And the management of skin toxicity is paramount to ensuring the patient actually makes it to the operating room on time.
Let's crystallize the IUCS perspective on sequencing and tumor board implementation. We need to define the new standard of care based on this data.
The algorithm is becoming much clearer. For patient A, who is cisplatin-eligible, the NIAGARA regimen neoadjuvant durvalumab plus Gemcis, followed by adjuvant durvalumab, is the new level 1 evidence standard. It improves EFS and OS over chemotherapy alone.
And for patient B, who is cisplatin-ineligible,
The EV-303 regimen neoadjuvant EV plus pembrolizumab, followed by adjuvant EV plus pembrolizumab, is the standard. The HR of 0.40 is too powerful to ignore. Radical cystectomy alone for these patients should now be considered inferior therapy, assuming they can tolerate the ADC.
this creates a significant sequencing dilemma, specifically regarding metastatic recurrence. If we use EV-pembro in the perioperative setting for the ineligible patient and they progress, what is the first-line metastatic option? The EV-302 trial established EV-pembro as the standard of care for metastatic disease.
That is the primary strategic conflict we face now. If a patient progresses within 6 or 12 months of adjuvant EV-pembro, we have essentially exhausted our best metastatic line of therapy. We are then forced to look at platinum-based chemotherapy, Gemcarbo or Gemcis, as a salvage therapy in the metastatic setting. It completely reverses the historic paradigm.
It effectively pushes platinum chemotherapy into the salvage setting for the ineligible population who failed perioperative treatment. It raises the question of rechallenge. If a patient is disease-free for 2 years after EV-303 and then recurs, can we rechallenge with EV?
There is no data to support that yet. The mechanism of resistance to Nectin-4 targeted ADCs is not fully understood. Resistance might be permanent. This emphasizes the importance of the initial curative intent. We are front-loading our most effective systemic therapies to maximize the cure rate at the time of surgery.
Another operational question for the tumor board is the duration of adjuvant therapy. EV-303 prescribes 9 total cycles of EV and 14 of pembro. NIAGARA is 8 cycles of adjuvant durvalumab. In a patient who achieves a PCR, a complete pathologic response is de-escalation possible.
The protocols mandate the full course. However, in the real world, toxicity often dictates duration. Specifically with EV, the cumulative neuropathy may prevent completing the adjuvant phase. The scientific question is whether the bulk of the benefit is derived from the neoadjuvant phase and the surgical consolidation.
The role of ctDNA will likely be pivotal here in future decision-making, potentially allowing us to spare adjuvant therapy in excellent responders. But today, we must follow the trial data.
Agreed. Until we have prospective data on ctDNA-guided de-escalation, the standard of care includes the adjuvant component. We cannot cherry-pick the neoadjuvant efficacy without committing to the adjuvant protocol that produced the survival curves.
We are seeing PCR rates approaching 60% in the EV-303 cohort. This brings us to a final provocation for you to consider. Are we moving toward a future where radical cystectomy becomes salvage surgery rather than the standard for a subset of complete responders?
It is the logical next step. If we can reliably achieve PCR in 60% of patients with systemic therapy alone, the morbidity of cystectomy becomes much harder to justify for everyone. The challenge remains accurately identifying those patients without surgical pathology. But yes, EV-303 and NIAGARA are likely the bridge to a bladder-sparing paradigm.
This concludes this session of the IUCS Journal Club. We have reviewed the definitive shift to perioperative ADC and IO combinations for muscle-invasive bladder cancer.
The data from EV-303 and NIAGARA provide a clear bifurcated path forward. It is now our responsibility to implement these protocols safely and effectively.